Good afternoon, everyone, and welcome to the Hartford Institute for Geriatric Nursing webinar series addressing current trends and issues impacting the health and well-being of older Americans. I'm Dr. Tara Cortes, the Executive Director of the Hartford Institute for Geriatric Nursing and a professor at the NYU Myers College of Nursing. This webinar launches our 25th anniversary as an institute, and I'm particularly pleased to say that we have had over 500 people register today to learn more about this important issue. Our program today, The Staffing Crisis in Long-Term Care, features national leaders who will discuss the crisis in recruitment, retention, and adequate staffing in long-term care. Let me first introduce you to our panel, and I will do it in the order in which they are going to be presenting. Our first speaker, Congresswoman Jan Schakowsky, was elected to represent Illinois' 9th Congressional District in 1998 after serving for 8 years in the Illinois State Assembly. In Congress, Congressman Schakowsky focuses on health care and senior issues. She was responsible for provision in the law to require improved review of insurance company premiums, nursing home quality protections, and initiatives to increase the number of healthcare providers, which benefit seniors and all Americans. A particular champion for our nation's seniors, the Congresswoman continues the fight to prevent the privatization of Social Security and Medicare and to make prescription drugs more affordable. She spearheaded the creation of the Seniors Task Force in the 111th Congress and continues to serve as the co-chair in the 117th Congress in the now renamed Task Force on Aging Families. Our second speaker, Dr. Ann Kolanowski, is Professor Emerita at Penn State College of Nursing. She conducts research on non-pharmacological interventions for symptoms of distress and delirium in people living with dementia in nursing homes. Her research has been supported by grants from the National Institute of Nursing Research, the Alzheimer's Association, the Hartford Foundation, and the Commonwealth and Neuroscience Nursing Foundations. She has published over 165 papers on dementia care in scientific journals and serves on many scientific advisory boards. Dr. Kolanowski was the founding director of the Hartford Center of Geriatric Nursing Excellence at Penn State University. And our final speaker is Dr. Robyn Stone, Senior Vice President for Research at Leading Age and co-director of the Leading Age Long-Term Support Service Center at University of Massachusetts, Boston. She is a noted researcher and internationally recognized authority on long-term care and aging policy, and has been engaged in policy development, program evaluation, large-scale demonstrations, and other applied research activities in these areas for over 40 years. Dr. Stone has held senior research and policy positions in both the federal government and the private sector, including serving in the United States Department of Health and Human Services as Deputy Assistant Secretary for Disability, Aging, and Long-Term Care Policy, and Assistant Secretary for Aging in the Clinton administration. We will first have a brief presentation from each panelist, and then we will have a discussion amongst them. We'll address questions from the audience during the last 15 minutes of the program. Please enter your questions into the Q&A box and use the chat box only for any comments that you wish to make. Now we'll begin with Congresswoman Schakowsky.
There we go. Thank you so much, Tara, and it's just an honor to be with you. Thank you so much to the Institute for putting this program on, and I'm honored to be with this esteemed panel of experts. And I know in the audience there are practitioners and academicians, and thank you for inviting me. So I have been involved in the issue of long-term care for a very long time, even before I was in the state legislature, when in Illinois I was director of the Illinois State Council of Senior Citizens. And let's face it, we do not have a comprehensive long-term care policy in the United States of America. We just do not. Families try and piece things together for themselves, sometimes successfully, often not so successfully. The amounts of money, the necessary care is not available. There's no system really for long-term care in the United States. We are hoping that we're making a beginning now in this reconciliation bill that we're passing, the Build Back Better bill, that puts some money into home and community-based services, but we have a long way to go to make sure that there's some sense of security as people age. You know, people have very little savings when they retire. Families. Their families are burdened, individuals are burdened, and many of our elderly, often women, who really have no support systems behind them. So today, though, we're going to be talking mainly about nursing home care, and I'm anxious to do that. But I also want to say, when it comes to nurse staffing ratios, I have a long history with that too, working with the nurses associations about setting limits, because we know, and I'm sure our experts know even better, the data that is in, that when you have proper nursing ratios, then everything improves. That you have better outcomes for the patients. You can have less turnover of the nurses. I have heard from hundreds of nurses who said that they sometimes have to actually leave the profession because they are so stressed by the fact that they can't adequately help their patients in all kinds of different settings because of the tremendous number that they have to serve and the burden. Lots of emotional, mental stress issues that nurses can face, and that's also true of the some of the less professional caregivers. So we're on a journey here that I think has barely started to make long-term care really functional in the United States. I know in Q&A we can get to some of the issues more in depth about the issues, but I did want to tell you about legislation that I have offered now in the Congress. We have too few co-sponsors, by the way. We only 21 right now, but we need to get more. HR 598, the quality care for nursing home residents and workers. And I wanted to tell you about the amount of time that, again, based on research, maybe some of you have done that research on what would really be adequate time spent on the job with patients. This legislation, again, I want to say the number, HR 598, I think is very, very important. And the requirements altogether are 4.1 hours per resident day of nursing care with a minimum of, I should say care, not all of it nursing, actual certified nurses, but 0.75, in other words, 3/4 hour of care provided by registered professional nurses, a minimum of 54 hours, of 0.5 hours. Let me say that again. The first was 0.75 hours, 3/4, and for a minimum of 0.54 hours of care provided by licensed practical nurses, and a minimum of 2.8 hours of care provided by a nurse's aide. So we're very specific. This goes with the science, it goes with the research of what would really make the difference. I know all of the problems that we can talk about later about the amount of turnover, how difficult it is to recruit, and what the reasons are for that. I'm looking forward to that discussion. But I know you want presentations from the panel. But once again, I want to say I think we have kind of a crisis right now. You might call it an SOS situation. Save our staff. And I'll end with that.
Thank you. Dr. Kolanowski.
Okay, thank you, Tara. I'm going to share my screen. Can you see my slides?
Yes.
Okay, thank you. Well, as the Congresswoman just told us, the adequacy of the nursing home workforce has really been a concern for decades. And while nursing services need to be understood from a systems perspective, where there's multiple factors that impact quality of care, today in my initial remarks, I want to focus on the adequacy of professional nurse staffing, RN staffing, because it's ignored to the detriment of the residents who live there, as well as the staff that work there. So just to make sure we're all on the same page, federal regulations currently stipulate that nursing homes need to provide RNs, LPNs, and direct care workers sufficient in number and skills and competencies to meet the needs of the residents. Additionally, every facility has to have a licensed nurse, and that can be either an RN or LPN on each shift. But only for 8 hours a day does that nurse need to be an RN. And this staffing model for providing care was passed back in 1987, and it hasn't been adjusted in 30 years to account for the medical complexity of residents that are now in our nursing homes. A recent study that came out of the Office of Inspector General found that for substantial periods of times, many nursing homes are staffing levels are below these federal regulations. And when you factor in acuity level into that equation, about 75% of nursing homes almost never meet these staffing levels. Rarely are nursing homes cited for violations here. For years, organizations like the Institute of Medicine and other professional groups have called for RN staff reform. Well, COVID-19 might be doing what these organizations have failed to accomplish. We know from the data that nearly 1/3 of US COVID deaths are linked to nursing homes. And in study after study, low RN staffing levels have been associated with more cases and more deaths due to COVID-19. RN staffing is key not only to infection control, but to a whole host of other quality indicators. And this is understandable given the responsibilities only RNs can assume by virtue of their education and their legal scope of practice. The RN is responsible for providing leadership in the delivery of person-centered care, and that includes health assessments and the plan of care for every resident in that facility, for the supervision of licensed practical nurses and direct care nurses who carry out that plan, and for coordinating care with the interdisciplinary team. Now, this past year, there's been a large group of expert geriatric nurse clinicians and scientists who have been working to bring this crisis in RN staffing to the awareness of the public once again, as well as the profession. Most people are absolutely shocked to learn what RN staffing is like in nursing homes, and that includes nurses that are in the profession but don't work there. through newspaper editorials and journal articles, we are advocating for 24-hour, 7-day-a-week on-site presence of an RN and further increases in RN staffing based on resident acuity and their care needs. And as the Congresswoman pointed out, we really feel the minimum standard should be 0.75 RN hours per resident for a total of 4.1 nursing hours total. We're hoping that there's going to be a light at the end of the tunnel. There is legislation proposed that calls for better RN staffing. The Congresswoman mentioned her bill, HR 598, and in the Senate, Wyden and Casey also have a bill. The National Academies of Science, Engineering, and Medicine have convened a committee on the quality of care in nursing homes. They have strong nursing representation on that committee, and that report should be coming out in a few months. And then to the naysayers, I do believe there are ways to build the RN workforce capacity. And I will stop there. I think we'll get into that in our discussion. So thank you.
Thank you so much. And now we'll turn it over to Dr. Stone. You're on mute.
Sorry. Thank you all so much. And for this wonderful opportunity to be with these two other fantastic speakers and to be in front of all of you. I couldn't agree more with what both of the speakers have talked about already. And I'm just going to add a little bit to that conversation. So here I'm going to try to share my screen and get to my presentation. And let's see. Let's get going here. So I want to talk a little bit in my formal 5 minutes, a little bit beyond what has been a lot of the focus on the nursing home staffing these days, and that is beyond the minimum staffing requirements in long-term care, and really thinking about understanding the staff competencies and the workplace culture that supports good practice. And I think everybody would agree that there are minimums under which we should not be going, and the RN issue is without a doubt one of the substantial concerns that we need to be addressing. But in my work over the years, you know, I've been looking at this over probably at least 30 years, trying to understand why we can't improve the quality of care and the quality of life for residents in nursing homes. And I would also argue the quality of the work life for the people that work there. And I think part of the problem is that we do not acknowledge that human capital is what produces quality. We have had a tremendous focus in the policy world on financing long-term services and supports and some kind of magical thinking around the delivery of long-term services and supports without understanding what staff needs to be in long-term services and supports, whether it's a nursing home, assisted living, or some of our home-based settings. And we absolutely need to be paying attention to this human capital aspect. In some ways, COVID has been a blessing in disguise because it has raised this issue to the fore when some of us who have been working on this for years haven't been able to do that same thing. It's unfortunate that we've gotten here this way. But I just want to start by saying that numbers do not necessarily translate into quality of staff. And in fact, we need to be careful that numbers don't start translating into having warm bodies. With that, I would say even warm body RNs. An organization that I will go unnamed was one of the staff people told me that they just finished a competency study of all the staffs in their nursing centers, including RNs and LPNs. 60% failed the competency tests. So we are not only having to pay attention to the numbers and the hours, but what are the key staff competencies that need to be part of this equation? How do we think about addressing workplace organization and job design so that we can do some of the things that Anne was talking about? I absolutely believe that we can have more RNs on staff. I also believe that we are still going to rely primarily on frontline CNAs and LPNs in our organizations. And so we have to figure out how we organize the work in a way that's going to support the whole team. And how do we address how staff work together during their shift and across their shifts? So we need for an increased focus on a well-trained staff. How well currently are incumbent and new staff trained? Do they have the right competencies for the job? You know, the nursing home is not a hospital, and the competencies that are required in an acute care setting or a primary care setting have some overlap, but there are some very unique aspects to long-term care, both the post-acute and the long-stay nursing home side, that need attention in terms of competencies across all clinical and managerial staff as well. We need to better understand the role of in-service and ongoing training to continue to support new skills and knowledge. I can tell you we've been in hundreds and hundreds of nursing homes over the years that I've been doing research. The in-service training is really terribly inadequate, as are the trainers, who are often part-time staff directors, and at the same time, they're doing infection control and a million other things. So there is not a good, strong focus on ongoing education. And then does the workplace actually support the staff to use the skills and the knowledge that they gain? If we continue to send people to training and we don't actually implement and build this training into everyday workflow, we've wasted millions of dollars on these training programs. So we have to think about this as the gestalt of the organization, just as we think about quality improvement for the residents that we care for. I really am arguing that we need to have CQI for the workforce. Look at how the work is organized. Are staff working to the top of their practice? I think Anne was really clear about this, and I think we absolutely have to be paying attention to this. What is the role of teams and shared decision-making? I was recently involved in a meeting where there was a lot of discussion about staff huddles, but let me tell you a dirty secret. I've been in many of these huddles and there's not a CNA to be found. And if you want knowledge about what's going on the floor in the unit, you need the eyes and the ears of those frontline staff in your huddles every single morning. And finally, I would like to talk a little bit and say that we need to have staff empowerment. That is the way that we are going to be able to develop a pipeline. We could talk about money. We could talk about all the other things that are also essential. But quite honestly, we got to keep our eye on the prize, which is it is these workforce staffing issues that are ultimately going to make the difference. I have seen very well-resourced organizations that do very poorly, and very, very dear, under-resourced organizations that do a fantastic job. And it's because they have the right staff at the right place, knowing how to work together and to solve problems. So finally, we have to demonstrate workplace CQI. Is the quality of the workplace measured? And how do we measure it? What kind of data do we need to improve on the workforce side? And then we need some objective indicators, including looking at things like job satisfaction, turnover rates, quality of supervision, and ultimately the use of healthy workplace measures and indicators in the internal work that our organizations do, as well as the oversight that our states and the federal government are involved with. And I'll stop there, and I really look forward to our Q&A.
Thank you so much, Dr. Stone. Wow, 3 wonderful presentations that have really set the table for our discussion. I've got some questions that I'm going to pose to the panelists. I'll start with one person, and if they'll, can help keep their answer to about a minute, then we can move on and get all the panelists' input. My first question that I'm going to ask is, Increasing the staff, and this is a big one, increasing the staff has a financial impact on organizations, especially since states determine the Medicaid reimbursement rate each year. And in some states, like New York, where I live, that has not changed for more than 10 years in spite of inflation. Without a change in the payment model for long-term care, how will nursing homes be able to financially support these minimum staffing standards? And let me start with you, Robyn.
Yeah, I think it's a very good question. I'm not sure that I have the total solution. I do believe that we have to tackle Medicaid nursing home reimbursement rates. In many states, they are insufficient to support our current staffing, let alone additional staffing. But I also think that organizations themselves need to take a look at the money that they are spending today. A couple of examples include how your training dollars are being spent. And are you actually being efficient with the resources that are currently being expended on staffing? And can they be redeployed in a way that you can begin to bring in more RNs and again, redesign the workplace so that you have more efficient teams working together on each shift and across shifts? So my argument is that we cannot look at just reimbursement and we cannot look at just staffing. We have to look at them together. But the more the evidence shows the importance of this increased staffing used appropriately, the more we're going to be able to make the argument that we must invest in this staff. And partly it's a societal issue. The consumers who pay taxes for Medicaid need to understand that they are not going to get better quality care unless we have better staffing in our organizations. No easy solution to this.
Thank you. Thank you. Representative Schakowsky, would you be able to weigh in on that one? And you've got to take yourself off mute.
Thank you. I just wanted to mention, I actually in the 115th Congress had a bill called Put a Nurse in Nursing Homes. This idea that only 8 hours is required for the most skilled for nurses. I think most families and residents would be shocked at that, and especially since the 8 hours can be during the day when the nighttime hours are often the most difficult and challenging times in a nursing home. But in terms in terms of the cost, so I think it's important to note that 70% of the money that is in long-term care come from federal dollars. Taxpayers are paying for that. So that's Medicare, Medicaid primarily, which, as far as I'm concerned, means that we have a lot to say about the accountability, about the transparency, about the requirements, since we are paying the freight as taxpayers. Additionally, I think we need to look at the structure of how are nursing homes being managed now. Increasingly, we see private equity, hedge funds getting into nursing homes. And I want to tell you, the primary goal is not necessarily the best care. The primary goal is to maximize profits. And so I really do think that oversight and regulation and looking at how federal how taxpayer dollars are being spent is very, very important here, because there's a lot of money. And I think what Robyn said, that she has seen some nursing homes that are, kind of perhaps underfunded, but have really good quality care, and others that are, quite lavish and yet have very, very poor care. We don't have standards. Maybe we need some kind of legislation that requires minimum competence in order to be licensed to. I think one of you I saw had mentioned that, or it was in notes that I had, that we actually set some minimum standards so that we lift all standards to a recent point. But right now, we know that over half of nursing homes have annual staff turnover of 100%. of 100%. So, how do we maintain staff? How do we recruit staff? How do we train staff? All of these issues are very important. All of them do require dollars. And so I think the whole examination of the systems that are involved in staffing nursing homes and maintaining the quality is so incredibly important and so incredibly absent right now.
That's a answer that really sets the stage for what is the second question here, which gets into that 100% turnover, which I think many people are very shocked when they hear that is what the turnover rate is in nursing homes. Recruitment and retention of staff now, post-COVID-19 particularly, has become near impossible in most parts of this country. And we're specifically speaking of nursing homes now, but we know it's true across the entire healthcare spectrum. Hospitals are also having a very hard time. There's not a pipeline of registered nurses or direct caregivers. Many healthcare workers have retired or just left the healthcare field. A lot of the immigration pipeline has dried up. How can we fix that? And let me start, Ann Kolanowski, with your response.
Okay, well, thank you for that question. This whole issue of recruitment and retention really has a lot of moving parts, and I want to kind of reframe this whole problem. Linda Aiken had a very good article, a recent article in the New York Times, and the contention was our problem is not so much that we have a shortage of nurses as having a shortage of available nursing care. So let me explain that. Right now, our RN workforce has been growing steadily. We have 5 million people with an active RN license. 3.5 million are employed in healthcare. Our schools of nursing have all seen increases in their enrollments despite the pandemic. They went up by 5% in this last year. But, and this is the big but, schools of nursing in this last year had to turn away 80,000 qualified applicants. And the reason for that was because they did not have the faculty and the resources to accommodate those students. So the problem is that we're not meeting the demand fast enough. There is a pool there. The second part of that issue centers around retention. We know that work by Peter Brujas, he tells us that there's going to be 1 million RNs that intend to leave the workforce by 2030. And a recent study found that almost 40% of new RN graduates say they intend to leave their job after the first year. Why is that? Because they feel that they are in a work environment that is not supportive. That is huge. Both those issues are modifiable. It's not like we're, stuck with this situation. So how do we address it? Well, I think in terms of the schools of nursing, we really need to ramp up our capacity to educate more nurses. We've got to get creative. Schools of nursing having partnerships with public and private organizations, the state and federal government. Let me give you a few examples I pulled out for this presentation. In 2020, the Maryland Higher Education Commission announced that they were going to give $30 million in funding to 14 schools of nursing to increase their faculty and student capacity. That's tremendous. Hawaii just created their preceptor tax credit. Healthcare providers who will serve as preceptors are eligible for that tax credit. So that helps build that resource base. The Minnesota VA healthcare system just committed $5.3 million to expand clinical placements and fund additional faculty at the University of Minnesota. I also think we could get a lot smarter with Title VIII funding. That has supported the supply and demand of nurses since 1964. I think we need to begin to focus on preparing nurses at the baccalaureate and higher degree level, because they are the individuals that are going to go on to become educators. Then the question becomes, if the pipeline does open, how do we get RNs into nursing homes? Because right now, only 7% of the RN workforce is in nursing homes. I know that students have told me, and I have seen this in the literature, their preference for working in a specialty really depends on the experience that they have in that area. And very few schools of nursing provide a top-notch experience in geriatric nursing in nursing homes. They say, the faculty feel that there aren't role models there. Well, a couple of solutions here. Hartford Foundation, for example, and the Jewish Healthcare Foundation are teaming up to revisit the teaching nursing home. They're setting up a model there that where advanced practice nurses work with the staff, but also with the student and the faculty to show them how this is really a complex, exciting area to work. Residency programs. We have those for the acute care settings. We've had students doing residencies there. Why can't we use CMS educational funding in the nursing homes to fund residencies? Federal loan forgiveness programs for nurses that work in nursing homes. So I think I'll stop there. I have a lot to say on the work environment, but I think we're going to get there. I loved what Robyn said, because I think it was just spot on about how we have got to change that in order to attract people and to make it a quality area. So
thank you, Dr. Kolanowski. And Representative Schakowsky, I'm going to move this over to you because you've been the champion of the Geriatric Workforce Enhancement Program and basically wrote the bill that justified or made it as a permanent program for geriatric education. Just speak just a moment or so about what that means, how that money, what it means to preparation of this kind of a workforce, and what else could be done.
Yeah, I mean, obviously we have to provide some more opportunity to make room in the workforce, and we have to train more people. And this was done in a bipartisan way with Dr. Burgess and the Republican side of the aisle, and that's important legislation. But I want to say too that we have to pay people for this work, and many of the direct care workers make something like $12 an hour around the country. And is there any wonder then that there is the kind of turnover? This is hard work. It is often done by women. It is most often women of color, and there is no then real respect in the job. There has to be the hours, the amount of time that they work, paid leave, and would absolutely be helpful if people who get sick. There were childcare that were available for people. So this is a really, really important and hard job, and yet we don't respect the workers sufficiently that are doing that. So it is, it's no wonder that we have this the shortage. Who can live on $12 an hour. That's absolute with no benefits. And you know what? We find some nursing home administrators who limit hours so they don't ever have to pay the benefits. And if they work full time, then they have to be paid more. So, administrators who are gaming the system. So, it's so hard in childcare and in elder care and in people with disabilities. Some of the most important work, the most you have to have the help, and yet the most underpaid people that we have. So we want to make it possible, provide more money for recruiting, provide more money for training. But unless we actually compensate people and treat them with respect on the job, it's just not going to happen. We're going to have these 100% turnover.
Mm-hmm. It's a great point. And we know that in many of the nursing homes during the height of COVID-19, we saw this a lot in New York, nursing home CNAs were working 2 and 3 jobs and going between and amongst different nursing homes because that is the only way they could make money. That's the only way they could support their families is to work 2 or 3 jobs. And of course, by going to the 2 or 3 different places, they would cross-contaminate.
And none of them provide benefits. And
right.
None of them take into account the transportation time between. I mean, there's so many negatives. Yes. Thank you.
Yes. Next question I'm going to ask is, are there workforce, well, I think you addressed this actually, Dr. Stone, in yours, are there workforce indicators beyond the number of nurses and direct caregivers that would promote an environment that attracts and retains staff? And I think what you presented in your talk basically clearly stated what those, and I think what Representative Schakowsky just said further adds some of the indicators are the pay scale. Are they competitive with the acute care system? Yeah. So I'm going to move beyond that question, and I'm going to ask, this is about nursing home administrators. There are no federal educational standards for nursing home administrators. Some states require associate degrees, some require a bachelor's degrees, and some require a master's in a health-related field. Should there be standards for education and competencies for this high level of leadership? And how do we ever get there? Let me start with you, Dr. Stone.
Sure. I'll respond to that, and then I have a couple of other things to say about the previous conversation. There are some efforts afoot by NAB, which is the national association that represents actually the licensing and the testing of nursing home administrators, to get federal standards and to also raise the visibility and the competency requirements of nursing home administrators. So there is attention paid to that, but I think it's a symptom of a much more systemic problem, which is that this is a completely undervalued sector. So if you look at the nursing home administrator requirements, again, I'm going to go back to nursing. It's great to talk about having more RNs, but we're not turning out RNs with any competence in long-term services and supports. And so it is very, very difficult to attract the best and the brightest into our sector. And then you have the front line, which, we've heard all of the challenges around it. This is where most of the turnover occurs. And one of the major reasons why staff leave, aside from money, is nurse supervisors. So the interaction between the front line and the LPN and RN are essential for us to pay attention to if we're going to turn around this turnover challenge that we have. This happened before COVID. It's gotten worse during COVID. So, I think we need to pay attention to the credentialing of all of the staff in our organizations. A competency-based orientation has just got to be there. We have to have knowledgeable, skilled leaders, whether it's an administrator, whether it's a line manager, a middle manager, or a clinician. They all have to have solid training, ongoing in service, because the field is changing dramatically. And then the supports to actually allow them to practice to their highest level of skill and scope within the work environment. And right now, it's such a systemic problem that it's hard to say that one solution, that there's one size fits all. The value of our sector is underwater. And, we can talk about the fact that these frontline, I call them caregiving professionals. We have 18 pages of competencies at leading age for direct care staff. They are not unskilled workers. They are not domestic workers. They are actually care professionals who are paid low wages. But the same thing holds true for our nurses, our social workers, and our executives. They are not on parity with the hospital or other parts of the health system. So, I think in order to solve this, we have to take a very holistic approach. And the nursing piece of this is critical because unlike the hospital, nurses drive a lot of what goes on in the nursing home. You never see a physician. I mean, you have a medical director, but, this is a nursing business. And I actually believe that we should be attracting a pipeline because there's tremendous opportunity for leadership and transformation by nurses and frontline care professionals if they understood what those opportunities were and were actually also getting compensated for it.
Great answer. Thank you. Do either of the other panelists want to add in?
I'd like to follow up on that. Thank you, Robyn. I totally agree. This problem, you have to look at the staff, their competencies, but I think you also need to look at the environment that people are in.
Sure.
And the leadership there is so critical for setting the tone. We know that when organizations have shared decision making, when they focus on well-being, quality care, when the staff are really important, we have less turnover.
Absolutely.
And then that less turnover in turn impacts resident outcomes. I mean, they're all connected. So we have to come at this from several areas, the education, the training, also the work environment. And then I think it's upon us that we need to get some positive models out there. Every time you pick up the paper, I look at the New York Times, there's some disastrous story about what happened in a nursing home. And then we wonder why students and nobody want to go there. We really need to get the word out that this can be a very exciting place to work.
So I agree.
Representative?
If I could, that's why I really do also think we have to look at the structure of the industry and the growing development of these hedge funds, et cetera, that are setting, you talk about setting the tone and, creating the environment. If the people who are looking only or primarily at the bottom line, that is not the culture that will inspire the kind of workers and the kind of care that is given. And we are seeing that happen more and more, that these are not locally owned in any way, that, and again, I point out that most of the money that goes into their pocket, it's taxpayer money, it's Medicare and Medicaid money. And so I think we need to exert, as a country, we need to exert these standards and these requirements. And if it is not as lucrative as some of these hedge funds, private equity companies want, then they can find some other industry to get involved in. But nursing homes is not the place where you're going to find your big bucks, is what we need to make as a statement as Americans.
I actually think there was a great comment in the Q&A just now, which is, and I say this often, this is not a real estate industry.
Yeah.
It's
Exactly.
a care and service sector.
Exactly.
And that needs to be front and center. However you want to look at it, that is the goal of these organizations, and that needs to be the purpose and the investment.
Exactly.
I'm looking at the questions, and there's some certain themes that go through them. And I'd like to just spend a moment or two talking about regulations and the regulatory environment of nursing homes, because most people recognize the regulatory environment for long-term care as being punitive instead of incentivizing evidence-based practice and quality care. And I guess I think, Representative Schakowsky, I don't want to put you on the spot, but I think maybe regulation is something that you are best prepared perhaps to talk about.
Well, maybe not to talk about, but maybe to try and implement. I am so what I have learned just from Anne and Robyn makes me understand how much work has really been done to look at the things that can improve the situation. And I'm so grateful for being part of this panel. And so I think that we need to get the input from the researchers, from all the academicians and practitioners that are doing this work, to say, what are the minimum things that we ought to be doing to set the stage now, and to to make sure that this all functions the way we want to. So, I am always there to introduce legislation, but rely on all of you who have done so much work to date on what are the laws that need to be passed. So I think it's a partnership that has to happen.
Mm-hmm. Thank you. Anna, Robyn, did you want to add to that?
I'll make a statement, and at the risk of sticking my neck out, as all of you know, I work for Leading Age, which is the National Association of Nonprofit Aging Services Providers. That includes nursing homes, but the full continuum. But I've been around a long time, and I was in policy way before I ever got it to Leading Age. I think that there is a role for regulation, and I think it's critical that we have regulation. And I think in particular, regulation is great at identifying and getting rid, hopefully, if we do good enforcement, of really bad apples. I don't think that just a regulatory process gets us beyond the mediocrity that I see in our sector. I was doing a podcast this morning, and I talked about the same thing. I'm not that concerned about the really bad apples. Hopefully we can get rid of them. I am concerned about the big middle of mediocrity that could be raised to a much higher level. And how do we do that? And that, I think, the representative was so clear that there needs to be input from the folks who know the best practice, the evidence that we need to put in, to inculcate, to invest in, to provide the incentives for, to help with technical assistance for organizations that don't know how to do it, to actually support best practice. And that is a different strategy from just a regulatory one. And for my mind, it's always been this question as a policy person: what is the balance between regulation and what I call a much more of a TA function? And we need to sort of figure out that balance, because both of them are necessary. The other is, as I said, I think we need more workplace indicators as quality outcomes. Anne said it. We have regression analyses that show a direct relationship between staff turnover and worse quality outcomes. It is a direct measure of bad quality. So that, we need to be using these indicators to help us to improve. So I am a fan of regulation. It has its place. And I think we need to figure out the other efforts, whether it's pay for performance, to create incentives for organizations that do well, and other kinds of mechanisms that we can use to support and really transform this sector.
Thank you. I think we have just time for one more question, and I'm going to put this back on Representative Schakowsky. I want to know how we've got a lot of participants out here and researchers here on the phone, academicians. What can we do? Number one, to help you get more support for HR 598, and to inform legislation on what we know and the research is showing. What can we do to help move this dial?
You know, I have, as I said earlier, I just feel like I have learned so much important information that will inform how we move forward. Now, we need to figure out a mechanism. I don't have a great answer right now of how that input happens, and how the connection happens, and how those who are doing the research, people and in academia, see and practitioners see their role then as working with the decision makers, people who help to get because you know federal dollars are so important in so many of these when we talk about long-term care, that we need your advice. So don't operate in a vacuum, but let's work together. Maybe the Institute or these two amazing experts, we can figure out a more ongoing process of how we exchange information and act on it, so that you know we're all in our different roles aiming at the same outcome, the same good outcomes, improved outcomes. And I totally agree with Robyn. It's not just another law and another enforcement mechanism and all that. And you know, between you, Robyn, and Ann and Tara, and you know, we should be able to figure out the framework and the processes and how we move forward together on this. I think we can.
Well, thank you very, very much. It's there's a lot of work to be done. I think we just have illustrated the tip of the iceberg, but the important tip. I think the points covered here between the workforce environment, and the laws and policies have been extremely important to understand. So I thank the panelists, Dr. Kolanowski, Congresswoman Schakowsky, and Dr. Stone, for such a wonderful, wonderful conversation.
Great. Thank you, Tara.
Thank you.
And thank you to our participants.
Bye-bye, everybody.
Bye-bye.
Bye.